Okay, so we're pleased to have today Beth Wolf from MUSC. She is assistant professor of biostatistics at MUSC. She got her PhD in biostatistics from MUSC. Her research interests are identifying high-order interactions, particularly related to biological markers that predict disease outcomes. And she's sort of kind of on the machine learning side of statistics. She has a large number of presentations that she has authored and co-authored, and also is a co-I on a number of NIH-funded grants. So again, if our sound doesn't get adjusted, you may want to get as close as you can. So Beth, all yours.
Okay, so can people actually hear me?
Yeah.
Raise of hands. Quiet. Without screaming in my office, I'm trying not to have to do that. Let me see if I control any other volume. Does this help?
No.
No, okay, that makes it worse for me. I can barely hear you guys. Okay. Well, I will talk as loud as I can, and hopefully you can hear. And again, stop me if you didn't understand or hear something, and we'll cover it again. So the work that I'm going to present today is motivated by a lot of the clinical interactions that I've had. So I work with a lot of folks who are interested in identifying potential biomarkers of disease outcome, and in general, their goal at the end of the day is to try to find some way to discriminate disease status, but to provide clinical guidance. And so rather than giving you a probability model where you have some probability of disease or no disease, they want to be able just to have the common clinician who's working in clinical practice out in the US be able to say, okay, my patient has marker X at this level, that suggests that they need further evaluation, that it suggests that they should be on this medication, something along those lines. And so this is sort of a statistical look at the ways that we might discriminate disease using a continuous outcome by doing some cut point selection, and sort of the statistical properties of that and approaches that we might take. So of course in medicine, we see dichotomization quite a bit. So certainly for various things like risk stratification and disease diagnosis and patient management, we see certain markers that are selected and a cut point is chosen. So like when I go to my doctor and they test my blood, they look for total cholesterol, and if my total cholesterol is high, in this case a greater than 200 milligrams per deciliter or higher, they might suggest that I need to be on cholesterol medication. So in that instance, it's suggesting that I'm at a higher risk of heart disease, and therefore there's a suggestion about how my treatment might proceed. We can also think about things like disease diagnosis. So I work a lot with the rheumatologists at MUSC, and they're interested in diagnosing people with lupus, and so they look at things like autoantibody levels to detect autoimmune disease. And so if you can have presence or absence of autoantibodies, but you can also have increased levels of autoantibodies, and if they're above a certain level, we might say that you're actually having an active disease flare. And similarly with that same population, we might use something like urine creatinine to protein ratio to help us determine the course of treatment in patients with lupus nephritis. And so clearly there's good clinical applications for this. Now, I will tell you from a statistical standpoint, statisticians tend to prefer not to want to make a cut point for a variable because we lose information that way, but that means that my job is to help you, if you need to make a cut point, try to find that best compromise that gives you the most information to most properly discriminate your disease outcome. So from a statistics standpoint, there are times when we do actually do this, and we say that it's a good thing. So again, if I'm talking about using it for clinical interpretation, it does simplify clinical interpretation. So thinking about that cholesterol example, certainly if I'm talking about a marker that's widely used in clinical practice and I'm telling a physician that they have to make a judgment call based on a continuous variable, then I'm sort of getting potentially very different care management strategies across physicians. Whereas if I say that some threshold, so in this case cholesterol greater than 200, actually indicates that you might be at greater risk for heart disease, then that might actually sort of standardize the way that physicians treat and manage their patients for something like cholesterol. From a statistical standpoint, we also sometimes require dichotomization during statistical implementation, and that's going to be sort of the last part of my talk. But if we talk about something like decision tree methods, so if any of you have ever worked with classification and regression trees, random forest, C4-5 trees. These are all statistical methods that data mine a large set of predictors and use cut points to just sort of define regions of risk for disease. And so in that case, I have to be able to dichotomize to define these regions where I believe people are at risk. But this is doing it rather than on a single variable. Now we're doing it for multiple continuous predictors, which may give us more information about disease status and therefore do a better discrimination. So that's sort of the reason for my originally doing this research in the first place. Now, if we think about trying to find an optimal cut point, we start with a simple case where we just have a single continuous variable. Let's say that you might have like a microRNA level that you were using in serum to try to assess whether or not somebody was at risk for a particular outcome. And then you have this binary outcome Y that's yes, no. It could be disease status. It could be just risk of disease. It could be whether or not you're likely to respond to treatment. And so while we could fit a logistic regression model, and I'm fairly certain that everybody in the room is familiar with those, we would determine from the logistic regression whether or not there was an association between X and Y. But again, it goes back to this idea that what I get back from the logistic regression is some probability of disease. Now, when we're making predictions from a logistic regression, we typically get a disease-positive or disease-negative answer when we make that prediction. But that particular prediction is based most of the time on whether or not your probability is greater than 0.5. Okay, well that may be the best point at which to choose your threshold for deciding that somebody's more likely to have disease, but it may not. And so rather than having this probability, we really do want to be able to provide some sort of clinical guidance about what observed values of X, that continuous predictor, are useful to determine whether or not somebody has disease or whether or not they need to change a course of treatment. So, of course, from the statistics standpoint, my challenge is if that cut point exists, I have to be able to find it. And that's actually a fairly challenging problem if you think about it. So I have some data that I observe, and I have all these values of my continuous variable X, and I have to figure out what value of X gives me the best discrimination for my disease state Y. So that's the statistical challenge that I'm trying to address. Now, there are a lot of cut points, a lot of methods for selecting cut points available in the literature, and I want to say, over 25. And there's, I'm sure, many more. You could think of a lot of different approaches to go about this. But in thinking about them when we started this project, we sort of categorized them into three separate areas. So the first area is methods that are based on some clinical or scientific knowledge. Okay, so this requires clinical or scientific experience and knowledge, and you choose a cut point based on that experience or knowledge. And so that's not the approach that I'm focused on here, because it's really assuming that we have a wealth of knowledge and years of observation of a particular continuous variable to know that that's a good way to dichotomize our data. And so it's sort of not based at all on the data, it's based on what we've observed as we've been clinicians over time. The second set of methods that we could talk about are based on prevalence in the population. So if we take a disease like lupus, it's not particularly prevalent, but you could base your determination of a cut point based on the prevalence in the population. If we take something more like heart disease, that's fairly common. And so clearly, as I vary the prevalence in the population, how I choose my threshold may actually matter, or, well, may actually differ. And so it turns out that we don't really want to focus on those methods either, because the data set that I have may not match the prevalence in the population. If I'm trying to study lupus, I'm clearly going to bias myself in the favor of having more lupus patients, because trying to identify lupus patients versus non-lupus patients given some continuous variable when I only have, 1% of my population having the disease, how in the world am I going to find the cut point? And so we're really not all that focused on this idea of prevalence. So the last set of approaches that we're going to focus on, and this is the bulk of this talk, is the data-driven approach, where basically you allow the data to help inform you as to where that best cut point is. And so even amongst that set of approaches, there's a large number that one could consider. See this on the next slide, or well, actually 2 slides. But what we have to think about from a statistics standpoint, my job as a statistician is to come and tell the people that I work with, so the co-investigators that I'm working with, what method should they choose? If I'm telling you that there's this variety of methods, how do you decide what one to work with and what's going to give you the most optimal cut point? And so in thinking about this, we have to start from a statistical framework in data where we actually know what the cut point is. And if I have data where I know what the cut point is supposed to be, I can then go back and compare the different methods and try to figure out which method actually will retrieve that cut point better than anything else. And so that was what the statistics part of this talk focuses on. So we start with a framework for defining an optimal cut point. And I will tell you from the start that this is not a very realistic data setting. And so we're going to start with this sort of unrealistic setting and move to a more realistic setting and see what guidance we might be able to provide. So again, we're back to where we have a single continuous variable x, and we have our binary disease outcome y. And we can define the relationship between x and y in this framework where the probability that y is equal to 1 is equal to this sum of two probabilities on the other side. And so we have the probability of y equals 1, given that x is greater than some value t, times the probability that x is greater than that value t, plus the probability that y is equal to 1, given that x is less than t, times the probability that x is less than some t. And in this framework, we're saying that t is the true cut point for x. And so basically that expression for the probability that y equals 1 is saying that if x is greater than t, I'm at some increased probability of disease that's constant. And if my value of x is below t, then I'm at some much lower value of having disease or having y equal 1. And so then in this framework, we have this true cut point t. And so we can start thinking about how do we find t based on the methods that are available in the literature. So the methods that we're going to focus on today can all be broken down in terms of a 2x2 table, which, again, fairly certain everybody in the room is familiar with. So now you imagine the normal 2x2 table, right? I have two binary variables. I have y equals 1 and y equals 0, and then I'll have x equals 1 and x equals 0. In this case, rather than x equals 1 and x equals 0, we're defining our rows as x greater than or equal to t versus x less than t, again, with t being that true cut point. So when we do that, we can see that we can define our cell quantities A, B, C, and D, where A is the joint probability that y is 1 and x is greater than t. Cell B is probability that y is equal to 0, but x is still greater than t. Cell C is then the probability that y is equal to 1, but x is less than t. And D is the value that y is equal to 0 and x is less than t. And of course, when we define it this way, then there are familiar statistics that we can calculate from the 2x2 table, things like odds ratio, relative risk, sensitivity, specificity. And so that's sort of the framework that we're working from, is the idea that we can generate this 2x2 table for any choice of threshold in the data. So when we do that, as I said, there's a lot of methods people use to dichotomize a continuous variable based on these statistics. And so this table here is just showing 12 of the statistics that people have reported in the literature as possibilities for choosing a best threshold or cut point given a continuous variable. And again, all based on the 2x2 table. So the ABCs and the ABCDs in the table all go back to that 2x2 table on the previous slide. It's like odds ratio, which again I think we're most familiar with, is just AD over BC. And then you have a whole slew of other statistics that you could consider as well. So in order to find the best threshold using these statistics, what you do is you allow t to vary and you calculate the 2x2 table, the A, B, C, D values from the 2x2 table, and calculate each of these statistics. And for most of them, you're either looking for the choice of threshold that maximizes the statistic or minimizes the statistic. So take odds ratio as an example. So if we considered all possible cut points for a continuous variable x in our observed data, we basically are going to go through and we're going to calculate for each 2x2 table that we could generate what is the odds ratio, and then we're going to choose that threshold that maximizes our odds ratio, which makes sense, right? So the larger the odds ratio is, the stronger we're saying that the association between our binary outcome y is with our continuous variable. So this is the framework that we're working from, and these were the statistics that we focused on in our study to try to understand the performance characteristics when we actually had a true threshold. So our question is, if I use these 12 statistics, which of them should actually recover that true threshold t? So, of course, I'm a mathematician, so I'm going to give you some theorems. The first theorem that we came up with, so recall on the previous page we had 12 statistics that we considered. It turns out that we can show mathematically that if I have some continuous variable x and a binary outcome y with prevalence where probability of y equals 1 is set to p of y equals 1, and we have this true cut point t defined in the way that we originally talked about, where above t I have increased risk, below t I have lower risk. we can actually show that by maximizing the odds ratio, the chi-square statistic, the kappa statistic, the Gini index, the Youden statistic, or the relative risk, these statistics should actually recover that true threshold t. So of the 12 that I started with, it turns out that there's 6 of the 12 that should actually recover that true threshold, that true cut point, when it actually exists. So we can also show this numerically. And so in these data, what we had is we generated some data where there was a relationship between a continuous variable x and a dichotomous variable y, and we looked at the statistic as we varied the choice of thresholds. And so the red line in the plots is actually showing me where the true threshold should be, and then the black line is showing the distribution of the statistic as I vary the threshold. So the threshold is on the x-axis, the value of the statistic is on the y-axis, and you can see we're going across. We have all the 12 statistics I showed in that first table. And so what you'd like to see is that the maximum occurs, the maximum or minimum occurs where the red line is. And so we can see that this is true for the odds ratio, Youden statistic, chi-square statistic, kappa statistic, Gini index, and relative risk, but not true for misclassification or any of the other statistics that are shown there. So from a statistician's point of view, I'm certainly arguing that those 6 statistics are going to do a better job of selecting my optimum cut point than anything, so sort of these guys down here, are not going to do a very good job, and in fact they're going to give me suboptimal cut points, whereas the 6 up at the top should in theory find the correct cut point. Now, part of a statistician's job is understanding, again, the performance characteristics of these things. So I have 6 possible choices that should find a true cut point for me, but the problem is that doesn't mean they perform equally well. So in order to understand the performance characteristics of these 6 statistics that we're considering, we ran a simulation study where we actually simulated data that had certain parameters and looked at whether or not we could recover that cut point t. And so the parameters that we considered were the strength of association with y, and this was defined by an odds ratio. The location of the cut point, so you can see that in this column here, so the probability that x is greater than t, so the smaller the probability that x is greater than t, then the larger the cut point. We looked at the prevalence of y, and we also looked at a cohort design versus a case control design. So of course in a cohort design I'm getting back to that idea of prevalence, but more than likely I'm not correct when I sample from a population about the actual prevalence of disease, so the case control makes more sense. For what I'm going to talk about today, we're going to focus mostly on the strength of association with y, so that this odds ratio column here, and the location of our cut point, which again is based on that probability that x is greater than t. So, when we looked at these, we wanted to evaluate basically how well did each statistic of those 6 that should work recover the true cut point that we believe to be there. Now, in this slide, what you'll see is we have the 9 simulations, the 9 scenarios from the previous page. So we had an odds ratio with our 3 cut points, an odds ratio of 3 with our 3 cut points, and an odds ratio of 6 with our 3 cut points. And in our slide, that corresponds to, for the choice of threshold, that corresponds to the columns. So we have the probability of x is greater than t is 0.05, probability of x is greater than t is 0.2, probability of x greater than t is 0.5. And the rows then correspond to the strength of association. So odds ratio of 1.5 being our weakest, and odds ratio of 6 being our strongest. And what we ended up plotting was we looked at mean square error of the choice of statistic within the method and the bias of the statistic within the method. So basically comparing the true cut point relative to the one that we actually selected by the methods. And then we looked at the 6, in this case we looked at 5 of the statistics. So this was a case control design, and relative risk isn't appropriate, so it's not shown on the plots. But in terms of the plots, then you can see, I apologize that they're tiny. You can see the 5 statistics. So black is represented by odds ratio, red is the chi-square statistic, green is the Gini index, blue is the Youden statistic, and gold is the kappa statistic. And so we can sort of start by getting a general feel, first of all, for what happens with all of the statistics. As I increase the strength of association, as I increase the probability that x is greater than t. So as I increase the strength of association, we can see going sort of from top to bottom that in general almost all of the statistics do a better job. They have lower mean square error and lower bias relative to a weaker association. Similarly, as I move across from probability of x greater than t being small, 0.05, to it being relatively large, I also do better in general with most of the statistics. And so again, you see this decrease in mean square error and bias. Now within the statistics, certainly it suggests, we're getting a suggestion from the slide that the kappa statistic is one of our best performers. I mean, if I look at each of the plots, the goal point is closest to that 0, point, which suggests that there's no bias and no mean square error. And then probably followed by Youden's and Gini and chi-square cluster. And oddly, odds ratio is, so maximizing the odds ratio is the worst choice. It really doesn't perform very well in a majority of the simulation scenarios. So it's the black dot that's furthest away from 0 in this first slide, first plot. In the second plot, again, still much more, you have similar bias to the other statistics, but much more error in the choice of t. Same thing in the next plot, and so on and so forth. So you can sort of see as you increase your strength of association, increase your probability of x greater than t, you get equal performance of most of the statistics with the exception of the odds ratio. So we also kind of want to get a better feel for what's going on in these regions down here, and so I blew them up a little bit so you could get a better feel to see if there was any separation of those four statistics relative to one another when you go towards the higher strength of association and a greater probability of x greater than t. And even though the slides in this case are blown up, for the most part, you really don't see all that much of a difference. So still, you're kind of seeing that they're all clustering around 0, again, with the exception of odds ratio. So at that point, they're performing equally well in this simulation setting. So again, this is the case where we're saying that this true cut point actually exists. So just in summary of those, we've already seen that as you increase your strength of association or the probability that x is greater than t, all of the statistics tend to improve in their ability to recover that cut point t. The only exception, of course, is odds ratio, and it turns out in the case control setting, relative risk is also an exception. They tend to not do quite as well as all the other statistics, even as the strength of association increases and the probability of x greater than t increases. In this setting, the kappa statistics seem to exhibit the best performance, and Gini and chi-square statistic were relatively close, particularly at the higher strength of association. So the problem is, great, I've shown in some simulation scenario that doesn't really mimic real life that the kappa statistic seems like the best performer, followed by chi-square and Gini, but what do I do in practice? That still doesn't give me a great choice. And so the other thing I would point out, as I mentioned earlier, this is not a particularly realistic setting. The way that we've defined this relationship so that we have a true cut point is you end up with a step function. So below my cut point t, I have a constant probability of disease, and above my cut point t, I have a constant probability of disease. Well, in reality, we don't actually believe that to be the case. Biologic data are not going to, at some magic threshold t, suddenly you're going to have this increased risk of disease. That seems extremely unlikely. And so we wanted to consider some other scenarios and see what happened. So rather than looking at that step function, we considered a couple of other relationships between x and y to kind of figure out what the distribution of our threshold should look like. And so we looked at a linear relationship between x and, it's more linear, between the x and the probability that y is 1. A near linear logistic relationship where, again, even though it's the relationship between x and y is logistic, I'm still seeing this sort of nearly linear increase in the probability of y as I increase x. And then we looked at a moderately steep logistic and a steep logistic. I have pictures of all these on the next page to help clarify what exactly that means. So the black line shown here is that step function that we were just talking about simulating. And again, we really don't believe that that mimics anything in biology. So never do we believe there's actually this true cut point. The reason we chose to do that is so that we could figure out whether or not we could recover that. Now, you can imagine potential scenarios that mimic any of these other situations. So if we think about the linear or near linear logistic, what that's saying is as I increase my value of x, I'm seeing a near constant increase in the probability that y is equal to 1. And from a statistical standpoint and even a clinical standpoint, really we don't want to choose a cut point for either of those scenarios because you're losing too much information. But if we think about the cases where we have the moderately steep logistic and the steep logistic curves, you could see that if we had any cut point that fell somewhere in this inflection region for these two lines, they might actually represent a good cut point because you do sort of have this rapid increase in the probability of disease as you get into this region. And so you kind of want to have your cut points by these methods fall somewhere in this region of these inflection points. So again, I mean, the argument is there are cases where we don't want to select a cut point, and ideally you'd like to be able to make that distinction that a cut point isn't appropriate because your relationship is nearly linear. But you'd also be able to like to make the distinction when there is the possibility that a cut point should exist. And so what we did is, as a statistician, I simulated more data that followed these 5 curves, or 4, because we've already looked at the step function. But I did a simulation looking at the near linear logistic, the linear model, the logistic model, and the steep logistic model, and looked at the distribution of cut points that I got back when I simulated those data. And again, you're looking for them to be somewhere around the inflection point. And so box plots of the distribution of these statistics is shown here. The good thing, so we're going from the linear to the near linear to the moderately steep logistic to the steep logistic, and you see that the box plots are suggesting that the cut points being selected, are the variability around that is getting tighter and tighter. Okay, that's good. That suggests that you can potentially make some distinction between the methods. The bottom plot is then showing 4 of my 2 quote-unquote best performers from the original simulation, my kappa statistic, and I think I picked chi-square statistic in this case. The kappa statistic is shown in red, so the solid red line is the median, and the dash red lines are then the 95th percentile around that. It's actually the mean, the mean, and then the 95th percentile around the mean for the distributions that I observed for each of the simulated data sets. The green is showing for actually I take that back. The green is the kappa statistic and the red is the chi-square statistic. So the red is the chi-square statistic and the green is the kappa statistic. And so the point in showing these, again, we wanted for the moderately steep logistic and the steep logistic, we wanted those 95% intervals around the mean to sort of capture those inflection points on the moderately steep logistic and the logistic curve. And we can see that for both the chi-square and the kappa statistic, we do that relatively well. So you're sort of looking at where the 95% intervals around the mean meet the inflection points. And for both cases, it works fairly well. But the flip side of that coin is, as we look at the linear and the near linear logistic, as I said, you really don't want to believe that there's a good cut point because you're sort of increasing linearly in your probability of disease as X increases. And so what you want is something that gives you a fairly broad confidence interval around the distribution of cut points that you might select for those particular variables. And so, in fact, what we see is though the kappa statistic and chi-square statistic both do a reasonably good job at identifying a region sort of encompassing the inflection point for the moderately steep logistic and the steep logistic, for the linear and the near linear logistic, the kappa statistic provides much too narrow of a confidence interval. And so you might be fooled into thinking that that was actually an appropriate variable to develop a cut point for. Whereas for the chi-square statistic, they're covering nearly the entire range of X that we observe, which would suggest there's not a good cut point. Okay, and so we have a way to start thinking about what method we might actually use in a realistic data setting. So at this point, I mean, of the 5 statistics that we're considering, it suggests that the chi-square statistic is the one that's likely to capture sort of this steep inflection if it exists, and give you a hint that you really shouldn't be selecting a cut point in something that's linear or near linear. And we say it's showing the same kind of thing here. So the red line is actually showing the distribution of the data. So this is the red line is the probability of Y as you increase your X. And the histogram is showing the cut points selected by the kappa statistic on the top and the chi-square statistic on the bottom. And again, what you're seeing is for the linear and near linear, the chi-square statistic is doing a good job. It's basically giving you this whole range that covers all of the data, which suggests you shouldn't use a cut point for those data. But then you're getting this narrowing as I get into the moderately steep logistic and logistic of the distribution of cut points that I observe. Whereas kappa is sort of skewed towards the right. So though in the simulation where we had the step function, it suggested the kappa statistic did the best job at picking T, kappa doesn't do as good of a job at discriminating when I shouldn't choose a cut point because my data really don't suggest it. And so, again, based on these 2 results, I would sort of advocate that the chi-square statistic is, of those statistics, the best choice. And then we also did bootstrap sampling just to kind of get a similar feel. Oops, sorry. I'm thinking I can scroll down and I can't. In this case, again, you're looking at the linear, and then so this is coming from a single data sample. So if I only had one data set and had to make a decision about this, would bootstrap sampling allow me to figure out whether or not the spread in my choice of cut points was too wide or not? And so on the top, we're looking at the chi-square distribution, or the distribution for the chi-square statistic. On the bottom, we're looking at the distribution for the kappa statistic. And this is a little less clear than the last slide, but certainly the kappa statistic, particularly for the near linear logistic, chooses too narrow of a range and would suggest that you should choose a cut point, whereas the chi-square distribution is still a little bit more spread out. And so again, I would advocate that if you're trying to make a choice and determine whether or not you should choose a cut point, you do this bootstrap sampling and look at how broad the distribution of your chi-square statistic was, and it should give you a good feel for whether or not you should select a cut point. So of course, this simulation did have real application, actually two, and so we're going to talk about two real applications and how we might view these data. So the first study I'm going to talk about is the Bioprotect study. This was an ancillary study from the Protect trial. The original Protect trial was examining progesterone as a treatment for traumatic brain injury, but they also wanted to look at serum markers to figure out if they could determine whether or not somebody was likely to have an unfavorable outcome. And so here's 4 of the predictors that they looked at. They looked at GFAP, S100B, SDP 150, UHC-L1, and we're still working on the publication for this, so unless you happen to know what those are, I'm not going to tell you. But they're markers that you can evaluate in the serum. And so at the end of collecting these markers, the clinicians wanted exactly what I talked about at the beginning. They wanted to say, can we establish some cut point to discriminate good versus poor outcomes in this population, so that if a person is seeing a regular neurologist who's out in clinical practice, then the clinician has some guidance as to whether or not they're doing well. So I'm looking at these particular markers, and so we actually took the log of all of them just to meet model assumptions. But when we took the log of them and we did this idea of, we took bootstrap distributions and looked at the choice of cut points by the chi-squared statistic under each bootstrap distribution, again, we're looking for something that's relatively narrow compared to the range of data that we observe. And you can see that in this case, for all of these markers, with perhaps the exception of SBDP, you actually come up with a fairly narrow range. And this is based on 500 bootstrap samples of the data. So despite my arguing with the clinicians against choosing a cut point, these data would suggest that perhaps one actually might exist and might be useful for at least 3 of the 4 markers. Now, in another application, we were looking at trying to predict treatment response in patients with lupus nephritis. So people with systemic lupus erythematosus often develop lupus nephritis, and the problem is when you start to treat lupus nephritis, a lot of the treatments that they use are cytotoxic. And so you'd like to be able to identify those patients that are responding well to treatment and those that aren't. So basically, if somebody's not responding well to treatment, you'd like to be able to switch to something else to avoid unnecessary toxicity. And so you need to be able to distinguish between responders and non-responders. And so again, we were looking at serum markers and trying to figure out what might suggest a high probability of treatment response. The common clinical markers that they use are the estimated glomerular filtration rate and urine protein to creatinine ratio, but then we were also looking at OPG and interleukin-2 receptor alpha as 2 potential markers. And again, one of the things that we were interested in answering was, is there a cut point in any of these markers that makes a good distinction between responders and non-responders? So now we did the same kind of thing that we did with the Bioprotect data. We did this bootstrap sampling and looked at the distribution of the chi-square statistic threshold choice in the bootstrap samples. And unlike the Bioprotect study, I would generally say that no, for the most part, maybe IL-2R alpha. But OPG, EGFR, and urine protein to creatinine ratio all pretty much, when I did the bootstrap sampling, covered the entire range of data, which suggests that you're sort of getting this linear relationship. So as EGFR increases, I'm seeing increasing likelihood that you're a responder. Same urine creatinine to protein to creatinine ratio, same kind of thing. And same with OPG. Again, the only one that might be able to discriminate would be interleukin-2 receptor alpha. And so, unlike the Bioprotect trial, there seems to be a bit clearer picture here that a lot of these really shouldn't be cut You shouldn't have cut points. Okay, so in both of those clinical studies, we considered a bunch of clinical markers for, in the case of the Bioprotect study, we did actually only consider those 4. In the case of the lupus nephritis data set, there were actually, I think, 18 total serum markers that we considered. I only showed 4 because that's too much information to show on one slide. But when we did the dichotomization, we considered the markers separately. And so one of the questions that came to light was, well, what if multiple markers are necessary to make a decision about clinical outcome? Certainly, we believe that for most complex diseases, so heart disease, cancer, lupus, any of these diseases, it's not just a single causal factor that causes you to have disease, not have disease, to respond, to not respond. And so we'd like to be able to pull in multiple information from multiple clinical markers. And so the question is, can we gain something by selecting the cut point for all 4 markers simultaneously? So using the information from each of the markers to help us better define the cut point. You know, and you can think about this going back to our original cholesterol example. So total cholesterol is not the picture of heart disease. It tells me one piece of information about heart disease, but we can also look at things like blood pressure, body mass index, and so having that information paints a bigger, broader clinical picture of whether or not somebody is likely to develop heart disease. And so again, it certainly clinically makes sense that we'd like to be able to use information from one marker. The second part of our research study, we started looking at jointly dichotomizing 2 markers. So again, this is this idea of rather than I dichotomize marker A, and then I dichotomize marker B, and then I dichotomize marker C, can I use the information from all the markers to help me determine the best choice of cut points for each of the markers that gives me the most information and gives me the best discrimination for disease status? So setting up a very similar framework to before, rather than having a single continuous variable x1, we now considered a case where we had 2 variables, x1 and x2. And actually, you were only at increased risk of disease if x1 was greater than its threshold T1 and x2 was greater than its threshold T2. So you can imagine I can divide the region of x into 4 squares, right, where I have you're less than T1 and less than T2, you're greater than T1 but less than T2, you're greater than T2 but less than T1, and the area where you're greater than both of them. And so we're saying for the simulation studies, our region of greatest risk is that joint region where both x1 and x2 are above their thresholds T1 and T2. And so this expression for the probability of y looks very similar to our original simulation scenario. It just involves now this combination of x1 and x2 having to be greater than T1 and T2. And so we're going to consider the same kind of things. So just as we did in the first scenario, we need to choose a best cut point, and so we have to consider a 2x2 table. Now this 2x2 table, which isn't shown here, is basically designed based on meeting this condition. So for that top row in our first table, remember we said x1 greater than t, or x greater than t versus x less than t. In this table, we would have x1 greater than t1 and x2 greater than t2. And our bottom row would be one of those conditions isn't met. So either x1 is less than t1 or x2 is less than t2, or both of those things are not true. When we do that, we can then order the values of x1 and x2. And in this case, when we were looking at this joint dichotomization approach, we ended up dropping the 5% of most extreme values because none of the statistics that we're considering perform all that well in those regions. So if we think about constructing an odds ratio and my cell counts in my 2x2 table are low, we don't get a very good odds ratio estimate. The same thing is going to be true with the chi-square statistic, with the Gini Index, the Youden statistic, etc. And so we order the values and we drop those 5%. And then we can, for each choice of cut point for x1 and x2, we can calculate cells A, B, C, D for our 2x2 table and maximize the statistics in the same way as we did in the first scenario. So we did a similar simulation. The only thing that changes here is, so I still have the probability that x is greater than t, and in this case, it's true for both x1 and x2. So where I say p of xi greater than ti, so if it's 0.05 for x1, its probability of x1 greater than t1 is 0.05, and probability of x2 greater than t2 is 0.05. But we also considered the correlation between x1 and x2. So we certainly can imagine a scenario where I had 2 markers that were highly correlated with one another. So if for heart disease you're looking at my total cholesterol, my triglycerides, clearly those things are related to one another. And so we considered a case where x1 and x2 had no association, where they were positively correlated and where they were negatively correlated. And then the same association. And so we're showing the same panel as we showed before, but now we're comparing marginal dichotomization, where I only consider x1 by itself and ignore the information from x2, and I only consider x2 by itself and ignore the information for x1, versus this joint approach that we're proposing here. And ideally what you'd like to see is that the joint approach does better than the marginal approach. Now, we find, again, same setup, so we're looking at the mean square error and bias of the statistics, so their ability to correctly choose that threshold t by strength of association in my rows and the probability that x is greater than t in my columns. I'm only showing the results for the choice for T1 here as opposed to T2. They're very similar. And so you can generalize to the other setting. But what we're seeing, so joint is the star and marginal is the circle. And again, our colors are the same. So odds ratio is black, chi-square red, Gini green, Youden's blue, and kappa gold. And so what you see, so let's start with this first corner plot here. You see the same trends where if I increase my strength of association, I do a better job. If I increase my probability that x is greater than t, I do a better job. Though the strength of association has much less of an effect in the joint case than it does when I'm only considering a single variable. But if I look at the joint versus marginal statistic for each of the plots, one interesting thing happens. So back to the case where we were only considering a single variable, our worst performer was the odds ratio by far. When we do joint dichotomization, and we maximize our odds ratio based on both T1 and T2, it turns out, that's our black star here, we do much better with joint dichotomization than we do with marginal dichotomization, where I only consider x1 by itself or I only consider x2 by itself. And suddenly, the other thing I would say is odds ratio is doing much better than kappa statistic. So you sort of get this interesting switch in what statistics are appropriate depending on how you're choosing to use the method. Now, the kappa statistic is an interesting case. So the kappa statistic marginal dichotomization, so I'm dichotomizing x1 by itself, ignoring the information in x2, actually does a better job than its joint dichotomization. Now, for Gini and chi-square, which are my red and my green, I do about as well whether I choose to do joint or marginal dichotomization. And for Youden's, it's hard to see the blue dot, but the blue dot is under the gold and the green and the red star, and we're doing better with marginal dichotomization than joint dichotomization. So if we look at these in a little bit more detail, we see the same behavior as we increase our strength of association. So now we're focusing on the odds ratio of 3 and the odds ratio of 6 plots. And where we increase our probability that x is greater than t, so 0.2 and 0.5 versus the last slide, we had 0.05, 0.2, and 0.5. And you see similar trends, but again, everybody's doing fairly well. For here, you're seeing more of a distinction with the Gini and the chi-square statistics, so these red and green solid dots relative to their joint dichotomization, which are the red and green stars. So you do better, in general, you do better with the Gini and the chi-square statistic if you use joint dichotomization. Same thing with the odds ratio. And for the most part, odds ratio is our best performer. The only exception appears to be when my strength of association is stronger and my probability of x greater than t is large. And it's still doing well, but clearly not as well as everybody else down here. So a little less clear picture when we do the joint dichotomization. If we consider a case where we don't, so that was the other thing. The last two slides, the correlation between x1 and x2 was 0. If we consider the case where the correlation is not equal to 0, you actually see fairly similar behavior. Still, for this first panel, odds ratio is doing the best when I do joint dichotomization relative to every other statistic, regardless of joint or marginal dichotomization. As I increase, so this is just looking at rows 5. As I increase my correlation, you're still seeing a very similar picture, but the correlation actually gives you information, and you do a better job with all methods. So this is correlation of 0 versus 0.5 versus negative 0.5, and so you're getting tighter and tighter and closer to this 0-0 region as you increase your correlation, or not even increase, but as you have correlation between x1 and x2. Okay, so in summary of those results, so if x1 and x2 are associated with y through their relationship shown there, so basically, again, that's that region, you have to both be above T1 and T2 to have increased risk of disease. Maximizing the odds ratio, chi-square statistic, relative risk, and Gini index end up with smaller mean square error and bias using the joint dichotomization approach compared to the marginal dichotomization approach, while Youden's and kappa actually do better with the marginal approach. However, across most of the simulations, the odds ratio gives us the smallest mean square error and bias, and so for joint dichotomization, if I was trying to dichotomize two variables, it really presents the best choice, at least in simulations. Okay, so we haven't yet done joint dichotomization for the Bioprotect data, the lupus nephritis data, but we'll talk about why. So the other thing that I said from a statistics standpoint, part of the reason that I'm interested in this is I really am interested in finding these combinations of variables that give me regions that are telling me about high probability of disease. So any disease I can think of that's a complex disease, and cancer comes to mind, but also lupus. I work again a lot with the lupus folks. So you can imagine that there are subgroups within the population that are defined by genetic features, that are defined by environmental exposures that they've had, that make them uniquely at risk for disease. And they're entirely different from another population that's uniquely at risk of disease. So decision tree methods are non-parametric and semi-parametric classification models that are easily interpretable in a clinical setting, but they also allow you to sort of define these subregions where people are at more risk for disease. And so they're of great interest because they allow you to combine multiple predictors and they help you define these subgroups that are in your population. They also require dichotomization, either when they're building the model or prior to building the model, and so that was the original impetus for any of the dichotomization studies, was for this application in decision tree setting. So two of the most popular methods are classification regression trees and logic regression trees. I'm guessing some of you have heard of CART. I don't know how many people have heard of logic regression. It was only developed in about 2005. And for both of them, as I said, continuous predictors are dichotomized at some point in model fitting. Now, there's a slight difference in these. CART has been around for a while. I think it was developed in 1988 by Leo Brayman. And so what it does is it divides the feature space, so all my predictors, into disjoint sets of rectangles and predicts class of a person based on the most frequent class in the region that person ends up in. And it uses something called a greedy search algorithm to select the cut points as it's building its decision tree. Now, logic regression, which was developed in 2005, uses logical combinations, Boolean, so ands and ors, combinations of variables to build its tree, and predicts class based on meeting at least one criteria in the tree. And it uses something called simulated annealing. The problem is it requires that all predictors are dichotomized prior to model fitting. So CART dichotomizes as it's building, logic regression dichotomizes beforehand. Or, well, you have to dichotomize beforehand, and then logic regression can fit it. So if we think about these two particular tree examples, we consider a statement here. So we have the probability of y is equal to 1 is equal to the relationship where x1 and x2 are both equal to 1. So x1 and x2 are now binary variables. Or x1 and x3 are equal to 1. So this is saying, imagine I had gender, I had races, African American or Caucasian, and I had, I'm trying to think of another dichotomous variable that we could use in people. Let's just say age greater than or less than 60. So let's say that x1 was gender, x2 was African American or Caucasian, and x3 was then age greater than or equal to 60. So this relationship is saying if we say one is male, if a person is male and they're African American, they're more likely to have disease. Or if a person is male and they're greater than 60, they're more likely to have disease. Okay, so it gives you this flexibility of relationships. Now, the binary variable thing is, of course, a bit of a problem, but logic regression requires it. So if I compare this probability statement, I can actually generate a corresponding classification CART tree and a logic regression tree, and they're shown in the pictures here. 1A is the CART tree. So the way that CART works, it goes down and it dichotomizes, even for a binary variable, it's still going to dichotomize. So it says if x1 is less than 0.5, then you go down this branch here, and we predict you not to have disease. If x1 is greater than 5, we go down the right branch, and we come to another decision we have to make. So now we say, is x2 greater than 0.5? Okay, well, if x2 is not greater than 0.5, we go down the left branch again, and we get to x3. If x3 is not greater than 0.5, we predict you not to have disease. If x3 is greater than 0.5, we predict you to have 1. So this would be, going down this branch, x1 would be 0. Going down this way, we would have x1 is equal to 1, x2 is equal to 0, x3 is equal to 0 in this branch, and 1 in this branch. And alternatively, we could go down this path here where we said x1 is equal to 1, so we go to the right, x2 is equal to 1, we go to the right. And again, that's matching this relationship here, and we say that you have disease. Now we can do the same thing with logic regression, but you'll see that the sort of the branches that you have in the logic regression and the leaves that are at the bottom are different. So in here, it's a prediction of disease, yes or no. Here, it's what variable are we talking about, and it describes this relationship exactly. So this is saying if x1 is equal to 1 and x2 is equal to 1, or if x1 is equal to 1 and x3 is equal to 1, then I'm predicting that you have a higher probability of disease. So the reason I point this out is you can see there's a little bit more flexibility in a logic regression tree because I have these ands and ors that join my variables together. In cart trees, the only or I have is at the very top of the tree, and it's basically combining all the branches which are anded together. So this flexibility allows me to better define the relationship between my predictor variables and my disease status. But of course, in logic regression, I'm limited by the fact that I have to have all dichotomous variables before I can build the logic regression model. And so one of the things that we were interested in was figuring out if we could use this dichotomization approach that we had described earlier. So first that marginal approach, but then also that joint dichotomization. Could we then, within logic regression, be able to set it up such that logic regression could also be adapted to be able to use continuous variables and select the cut points as it went along, and then compare this back to cart. And so we ran a simulation comparing these two scenarios. This is just showing here we use the package rpart in R to fit cart and the logic reg package in R to fit logic regression trees, but we used the dichotomization approaches that I just described in order to dichotomize our variables for the logic regression tree. And then we just want to show who does a better job of recovering the correct relationships. So in this case, we had 20 variables, 10 of them were binary. So these are our predictors. 20 predictor variables, 10 were binary, and 10 were continuous. And we wanted to select cut points. We had cut points for x4, x5, and x6 that were set such that the probability of xi is greater than t is equal to 2.2. And then we generated a relationship as follows. Okay, so L is equal to the probability of y equals 1. So if x1 and x2 are true, so these are both binary, or x3 and x4 are equal to 1, and so that would be x3 is equal to 1 because it's a binary variable, but x4 is greater than t, or x3. Oops, there's an extra, so drop that one. And then finally, if x5 and x6 are true, so in that case, that means that x6 is greater than t and x5 is greater than t. So these are both continuous. This is a mixture of continuous and binary, and these are both binary. And then we generate our probability of y equals 1 based on this L in a relationship very similar to what we described in the dichotomization scenarios. So what we wanted to do is see how well did our methods do in recovering those true interactions based on a strength of association. So again, in this case, our strength of association is our rows and our interactions. So we had an interaction between x1 and x2, which were both binary, an interaction between x3 and x4, which were binary and continuous, and an interaction between x5 and x6, which are both continuous. And we wanted to see how well cart and logic regression did in their ability to recover these interactions exactly. Again, an increasing strength of association and a sample size increase. So we went from sample size 100 all the way to sample size 2000. And so for both methods, you see that as sample size increases, in general, they do a better job of recovering the interaction terms. And as strength of association increases, they do a better job of recovering the interaction terms. But in all scenarios, C-logic, which is in blue, and that's where we're using logic regression with the joint dichotomization, in all cases, logic regression is doing a better job than cart at identifying these predictors, with perhaps the exception being the smallest sample size, where neither does very well. So this does suggest that perhaps there's something to be gained using the flexibility of logic regression, but implementing a way of dichotomizing within the logic regression framework. So in this case, we see that logic regression does a better job than cart at discovering these interactions without an a priori hypothesis. The other thing I would point out is although cart doesn't do as good of a job as logic regression in exactly identifying the interaction, it does tend to find the interactions, it just adds in extra terms. And so cart finds them, but there's noise variables that get included. So at the moment, we're working on actually incorporating, right now we're dichotomizing outside of the logic regression framework and then fitting a logic regression model. I actually have a student who's working on incorporating the dichotomization within the simulated annealing algorithm so that C-logic can simultaneously look for cut points as it's fitting the model. In general, as a statistician, we do know that dichotomization leads to loss of information. And so we'd like to avoid it when we can, but sometimes in a clinical setting it's necessary and important to choose a cut point because it helps us guide clinical care. So as a statistician, therefore, I'd like to be able to provide the best guidance I can about choosing the optimal cut point to minimize information loss. And from this study, we've seen that the chi-square statistic in the marginal setting actually does a really good job, and regardless of whether or not it's a step function. So we saw that with the steep logistic and the moderately steep logistic, that it actually did a good job of finding those inflection points on the logistic regression curves, but still gave me a broad range on the near linear curves with the probability of y. And so that provides some guidance. We also said if we did bootstrap sampling and we saw that broad range of possible cut points chosen by the chi-square statistic, then probably we shouldn't use a cut point for that. So it does give you information both about the optimal choice of cut point and whether or not you should choose a cut point. So again, this suggests that there are strategies for dichotomizing variables that would make good sense and be useful in patient care management. I do need to thank a whole slew of collaborators. So Dr. Sybil Prince-Nelson is a recent graduate of mine who did much of the work on the dichotomization part of it, so all those simulations are tied into her work. Li Shang-Fan, Sharon Yates, and Yuko Pelish are all statisticians that were involved in the Bioprotect trial. And so Li Shang is also a recent graduate, and she is since moved on to bigger and better things. But she and I had the whole discussion about trying to come up with we're trying to deter the clinicians from choosing cut points for the Bioprotect trial, but she was the one that did the simulation work to figure out whether or not we should do cut points for the Bioprotect serum markers. Peter Green is my current graduate student, and he's working on the implementation of the dichotomization within the logic regression framework. Paul Neidert, I think most of you probably have met. So Paul Neidert and Ramesh were both also involved in the dichotomization work and were part of Sybil's committee. So I was also funded by multiple NIH grants, as you see there. One of them, of course, being our CTSA. So kudos to the CTSAs. Anyway, hopefully this has been useful, and like I said, it's designed to give guidance about A, what method you could use to select a cut point, and B, whether or not you should be selecting a cut point. The rest of it is sort of more my statistical interest in identifying interactions without an a priori hypothesis, so what was mentioned at the beginning in my bio. So hopefully you heard most of that. It's hard to say, but I'm happy to take any questions at this time if you have them.
So thank you, Beth. That was really great. Really enjoyed that. The question I had, if you can hear me.
I hear you fine.
Okay. Does this make a difference if the outcome is, or what effect was if the outcome is sparse or rare?
No, it's a good question.
So we did look at the sparse case. The problem is you basically don't have enough information. So you say sparse. So imagine that you had a data set with 10,000 subjects in it and your outcome was sparse, but you still observed 100 people that had it. That's, 1%? That's relatively sparse. In that case, potentially I could find it. I would have enough information to be able to find a good cut point. But if I'm talking about a small data set, really it can't be sparse. So that was kind of why we focused on the case control setting, because a lot of the data sets that I end up seeing for these biomarker studies are very small data sets. So for the lupus nephritis data set, I think we had 140 total participants, and I'm trying to think, I want to say roughly 30% of them were responders. So that's fairly sparse because I'm now looking at 30% out of 140, and that one is a little more questionable. Bioprotect, we had it was a phase 3 clinical trial. We had a large sample size, but certainly you do have an issue if you have a sparse outcome and not enough data to inform your choice of cut point. So I find that for sample sizes, if you had, say, less than 100 in both of your groups, you really don't have a very good ability to make that distinction, and you get a lot of bias and mean square. You also get a lot of variability. So if you did that bootstrap sampling like we did with the lupus nephritis data, in general, you don't get great distinction. So it's in thinking about those data, like I said, the IL-2R alpha marker was the one that seemed to suggest there might actually be a good cut point. But you would certainly want to validate that in a much larger cohort. And it's hard to come by because lupus is fairly rare, and lupus nephritis is a complication of lupus. So you have to have a population that first develops lupus and then also develops lupus nephritis. So then you're looking within the lupus population. And it's just hard to validate that kind of stuff. So in short answer to your question, if you had enough observations, you could look at a low prevalence outcome. But if you had a small data set, probably not. You really wouldn't have enough information to inform the model to make a decision about where that cut point was. Does that help?
Yeah, I mean that's the same kind of issue that we have when you trying to model from a smaller data set.
Mm-hmm.
If the outcome is sparse and you have all sorts of issues that you wouldn't have if the outcome wasn't so sparse.
Yeah, and so I mean, like I said, from a guidance standpoint, I would say if you had fewer than 100 per group, you get sort of questionable results that are highly variable from sample to sample. So like even in the lupus nephritis data, though the IL-2R alpha suggested a good cut point, like I said, I'd want to see that validated in a future cohort, because I don't really trust that data set having only 140 total subjects and only 40 of them roughly being responders. Mm-hmm. It suggests that so I look at those as pilot data. That's good pilot data that might be a good marker to make a distinction. But I would never go so far as to say, put that into clinical practice. Any other questions?
I have a general question, probably.
Yeah.
So, could you please explain a little bit, like, why we should use cut points? What are the benefits of including, rather than just considering the whole distribution?
Well, so I suppose as a statistician, I tend to sort of agree with your thought that I would really rather not provide any cut points. But I think when you go into clinical practice, most people are not. And this is nothing against physicians, but a lot of people are not very numerically oriented. And so if what you get back when you submit some clinical lab value is, oh, here's your probability, the choices that the physician has, they still have to make a decision on how to treat the patient. And so I guess the argument I would make here is for standard clinical practice, if I'm releasing a marker to the general population of physicians to use in their clinical practice, it's helping you to somewhat standardize the care that patients are receiving. Because otherwise you're getting varying degrees of, like, to one person, a 20% risk of disease is horrible. To another person, you're not going to worry about it until you're at a 60% risk of disease, depending on the disease scenario, etc. And so it might actually behoove, what I would kind of say is that it's maybe beneficial to provide both pieces of information. But we know in clinical practice, this is what we end up doing. We still end up having to make a decision regardless of whether or not the cut point was chosen for us beforehand or later. So, I mean, if you don't choose a cut point when a clinician is sitting with a patient, they're still going to have to make some decision about how to manage that patient's care. And what I'm saying is, if I provide you with a cut point that is data-driven and has been validated, I'm going to enforce that thought of validation, and has been validated, then at least you're standardizing the care that the way that a clinician is likely to manage a patient. Now, granted, as a physician, they're still going to look at a patient holistically and not just look at that one marker or one set of markers. They're going to look at other things about that patient. But it does help guide clinical decisions and makes it a little bit easier when you're trying to see 20 to 30 patients a day. So I could make an argument either way. Certainly as a statistician, I kind of cringe at the idea of dichotomizing, and in fact got into a statistical argument with somebody about this. But at the end of somebody still has to make a decision. And so the question is, do you want to leave the physician who's got the tool in hand that gives them a probability to make the decision? Do you want to leave that? Because the physician may just pass that on to the patient. And patients can deal with that information as they choose to. So that's really much more of a philosophical question at the end of the day. But like I said, from the standardized care point, I do think it helps standardize care, so that you're getting sort of a basic way of approaching managing and treating patients for common diseases. If you had markers for like cardio, like I said, when any of us goes to the physician, we all get blood work on cholesterol, we all get blood work on triglycerides, we get white blood cell count, and there's decisions about our management that's made based on those markers. So like when you go to the physician and your cholesterol is high and your triglycerides are high, they're more likely to suggest that you should be on cholesterol meds. You as a patient can regard or disregard, but that's, again, based on these cut points that have been chosen. I don't know when that cut point for cholesterol was established. And of course now we're questioning that with lipid fractionation, but it makes a good example.
So that's really wonderful. Let me expand on this a little bit from the point of view of a clinician. Clinicians hate probabilities.
Yes.
They've got to make decisions, and what clinicians tend to use is actually heuristics, sort of rules of thumb. And if we can use cut points in a way that help them make those rules of thumb a little bit better than arbitrary, that's pretty good. Mm-hmm. Now let me ask you about setting the cut points, considering how you consider an ROC curve and where you place yourself and the implications of false positives and false negatives. So consider two situations. You have a situation in which a false positive, you take the patient to surgery. They have very difficult surgery where the surgery is going to involve a major period of recuperation. Where a false negative, you just wait a few more weeks and get another test. Versus another situation in which a false positive means you go and you do a biopsy and it turns out to be negative, but a false negative means you're missing cancer. So the implications of your cut point can be very different depending on the values of false negatives and false positives. So how would you factor that into your kind of modeling? Or do we need to write another?
So, and that's an interesting point. So if you remember way back when I started the talk, I mentioned that we sort of, in our minds, we being the statisticians that did the simulation work on this, we categorized those methods into those that were clinically motivated, those that were prevalence-based, and those that were data-driven. And so what you're really getting at is the clinical motivation. So if you have a clinical motivation where either making a mistake when you say that somebody, so where there's a mistake that's bad. So again, either the case where false positive is really bad or false negative is really bad, then you really do need to have a conversation clinically about what that means. So, I mean, what we were doing was taking the stance of oftentimes if we're doing any sort of data mining approach or we have just a set of serum markers and we're just really curious, there may not be a clinical motivation for biasing it one way or the other towards more false positives and more false negatives. And so I think if there is a case where you as a clinician know that to be the case, that a false positive is has much more severe consequences than a false negative, then certainly I actually wouldn't advocate the data-driven approach. I would advocate trying to do something to control that and using like an area under the curve and picking a point at which that it gave you the characteristics that you wanted. I mean, you could think about it also in terms of sensitivity and specificity, same kind of idea. I mean, the clinically motivated approach is often I want to have at least, say, 70% specificity and then maximize my sensitivity or vice versa. Well, you could do the same thing with false positive and false negative rate. And that's not really data-driven. That's motivated by the clinical problem. And I think, again, from a statistician standpoint, though I was looking at this purely from a statistical motivation standpoint, well, I mean, not clearly, totally, but like the simulations were set up to be purely statistical. At the end of the day, if I'm doing this with somebody, I'm having a conversation with them about what is most important. Do they really care about just the best discrimination they can get, or is there a consequence that's severe if I make a mistake on one side or the other? And if they tell me that there's a severe consequence to making mistake A versus mistake B, then I'll probably change how I approach this. So I think your point is very well taken. This, regardless of how you choose to do this, this needs to be a two-way conversation between a statistician and the clinical person or a scientist interested in evaluating that biomarker. You know, I mean, I think about, like I said, the total cholesterol example that I'm using throughout. I think it's probably overly enthusiastic, but certainly if you misdiagnose somebody and fail to catch their heart disease, that's bad. So we'd rather, I think, take, you know, that, so I think there's some motivation that goes along those lines. Like I said, the approaches here really don't take that into account at all. They're very data-driven. Now, the CART modeling and the logic regression modeling that I were talking about at the end, can be set up to be probability models. And so you could then still combine the information from all of these predictors in a way that's clinically easy to follow and understand, but there could still be some probability assigned that you could sort of emphasize false positives or false negatives being a worse decision. So, and if you take the whole thing that I talked about it as a whole, really the purpose of my research at the end was getting at that decision tree piece. So I can combine that information and give you something where you could do then of that whole model, how do I decide false positive, false negative, but still combining the information from these multiple markers.
Fantastic. Thank you very much.
Thank you.